Hey everyone, it's Renee Rasted. I chose to do my master's project thesis presentation on osteoporosis. I chose this topic because I'm interested in orthopedics, and throughout my time shadowing orthopedics in undergrad, I saw how prevalent osteoporosis was in my hometown. I will be returning home after graduation and accepting a job in orthopedics, and I hope to bring my patients better access to osteoporosis treatment by incorporating it into the clinic's practice. In this PowerPoint, we will go over the clinical pearls of osteoporosis, including general features such as etiology and pathophysiology, clinical features including signs and symptoms and physical exam, diagnostics, prevention, and treatment. Osteoporosis is considered a disease of the bones in which osteoclasts act in a faster rate than osteoblasts. Osteoblasts function to build new bone, and osteoclasts function to break down old bone. So when osteoclasts work faster than osteoblasts, it results in a decrease in bone mineral density. Decreased bone mineral density, by definition, is osteopenia and osteoporosis, and we'll get into the differentiation of these two later on in diagnostics. Osteoporosis leads to weakened bones and fragility fractures. The incidence of osteoporosis has increased in recent years, with an average of 46.3% of women over 60 years old experiencing fragility fractures each year. Genetic predisposition plays a large role in osteoporosis, as well as modifiable risk factors. Risk factors including age over 60, postmenopausal women, Caucasians, smoking, low BMI, alcohol use, long-term steroid use, and parents with a history of fragility fractures. Osteoporosis is asymptomatic until it's not, and fractures occur. Fragility fractures primarily include those of the vertebrae, hip, and wrist, and these occur when a mechanism of injury causes a fracture that would not normally do so in a patient with a normal bone density. For example, a low-impact trauma like a fall from standing would not normally cause a fracture in the spine of a typical healthy patient. But with a patient who has weakened bones like osteoporosis patients, this is very likely. The most common fragility fractures in osteoporosis patients are vertebral fractures. Patients with fragility fractures will present with point tenderness to the area of trauma, decreased range of motion, and possibly weakness in surrounding muscles that attach to the fractured area. Osteoporosis can be diagnosed several different ways. The most common indicator of osteoporosis is a fragility fracture identified on plain radiographs of the spine, hip, or wrist. In addition to this, the clinical presentation of the patient's personal risk factors can help confirm the diagnosis. DEXA scans are the most commonly used screening tool to diagnose osteoporosis in the absence of a fragility fracture. Women are generally screened with a DEXA scan once they are 65 or older, or if they are younger than 65, postmenopausal, and have one or more risk factors. Currently, the evidence of screening men is insufficient to balance the risks to benefits of preventing fragility fractures. DEXA scans are graded using a T-score. A T-score of negative 1.0 or better indicates normal, healthy bone. A T-score of negative 1.1 to negative 2.4 indicates osteopenia, which is a less severe version of osteoporosis where bones are still weakened but not as bad as osteoporosis. In this stage, lifestyle modifications can be utilized and pharmacological therapy is not necessary just yet. A T-score of negative 2.5 or worse indicates osteoporosis and in this case warrants pharmacological therapy, which we will get into a little later. FRAX is another tool used to gauge the risk of fragility fractures. There are two different risks that can be determined. A 10-year hip fracture risk of greater than 3% is indicative of osteoporosis. A major osteoporotic fracture of greater than 20% is also indicative of osteoporosis. Both scenarios warrant pharmacological therapy. Addressing modifiable risk factors is the best method for preventing osteoporosis. Genetic predispositions such as gender, postmenopausal status, and parental fracture history are non-modifiable risk factors. But a good way to balance these risk factors, if they are present, is to address other risk factors. First, it's important to address the social habits of the patient, including limiting alcohol use and smoking. If the patient can, they should also avoid long-term steroid use, as research has shown that steroid use significantly increases the risk of osteoporosis and fragility fractures by interfering with bone metabolism, specifically osteoblasts and osteoclasts, which we talked about a little earlier. Exercise is a great lifestyle modification as well. Patients should specifically focus on keeping their BMI in a healthy range of 18.5 to 24.9. Patients should focus on low-impact cardio to reduce wear and tear on their joints, and strength training to build muscles for supporting their joints and preventing fractures. There are several options of pharmacological therapy for patients, with each having a different mechanism of action. Therefore, you can weigh your options for your patients and their personal factors to choose the best medical therapy for them. The first-line treatment for osteoporosis is injectable bisphosphonates. Zoledronic acid is an injectable bisphosphonate that may also be known by its brand name Zometa, Reclast, or Aclasta. These generally are administered as a once-yearly infusion. For patients that may not be able to tolerate injectables, alendronate or Fosamax, which is its brand name, is an alternative PO option that is generally administered either daily or once weekly, depending on the dosage. It's important to consider any potential compliance issues for your patient before administering alendronate, since it is taken at home on a specific regimen. In addition, it's important to note that esophageal erosion is a common adverse effect of PO bisphosphonates, so you should educate your patient on taking it with a full glass of water and to remain sitting upright for 30 minutes after taking it. For bisphosphonates in general, they function to inhibit osteoclast or bone breakdown. The maximum treatment length is 5 to 7 years. The most common adverse effects patients should be educated on is the increased risk of osteonecrosis of the jaw, hypocalcemia, esophageal disorders, and severe renal dysfunction. Therefore, patients at an increased risk of this should not take bisphosphonates and could try any of the second, third, or fourth line options. Monoclonal antibodies such as denosumab or Prolia, which is its brand name, and romosozumab or Evenity, which is its brand name, are the second-line medical therapy for osteoporosis. Denosumab functions by inhibiting osteoclast and preventing bone breakdown, and it's administered as one injection every 6 months. Recent studies suggest that denosumab can be used for up to 10 years, compared to outdated research that used to suggest a 1-year maximum. Romosozumab functions by stimulating osteoblasts and bone buildup, and it's administered as 2 injections once a month for a maximum of 1 year. Patients taking monoclonal antibodies should be educated on the adverse effects of muscle and joint pain. Patients who are at a high risk of infection or are actively infectious with other conditions should not take monoclonal antibodies, as these target the immune system more heavily than other medical therapy options for osteoporosis. Parathyroid hormone analogs such as teriparatide or Fortea, which is its brand name, and abaloparatide or Tymlos, which is its brand name, are the third-line medical therapy for osteoporosis. These medications function by mimicking parathyroid hormone and stimulating osteoblasts for bone buildup. These are administered as a once-daily injection for a maximum of 2 years. Studies show that they are not as effective in hip osteoporosis, and patients should be educated on the risk of rapid bone loss once they are stopped. Therefore, most patients usually switch to an alternative medication following the 2 years. Patients at high risk for hypercalcemia, osteosarcoma, or other metabolic bone diseases should not take parathyroid hormone analogs. Selective estrogen receptor modulators, or SERMs, including raloxifene or Evista, which is its brand name, are the fourth-line medical therapy for osteoporosis. This medication functions by mimicking estrogen and reducing the activation of osteoclasts to prevent bone breakdown. Raloxifene only targets the vertebrae and is administered once daily PO. Patients should be educated on compliance as well as adverse effects such as estrogen withdrawal symptoms like hot flashes. Patients who are at an elevated risk of venous thromboembolisms, such as those who smoke or have had previous clots in the past, should not take SERMs. Again, selecting the right medication for your patient is a careful process, and you should take consideration of your patient's personal factors while also allowing autonomy to collectively select which medication is best for them based on route of administration, time frames for administration, and adverse effects or contraindications. Here are my references used throughout the presentation. Thank y'all.